Good afternoon, folks. We're going to give just a few seconds for people to enter the Zoom room. We have a lot of folks joining us today. We're glad that you could be with us. So good afternoon. I'm Michelle Wagner with NAMI New Hampshire, and I work on the First Episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us for today's webinar, 988 versus New Hampshire Rapid Response versus 911, exploring mental health crisis response options. Today's presentation is being recorded, and you'll be able to find it on the education page of onwardnh.org. There's a short evaluation we're asking folks to complete after today's presentation. You'll also receive a follow-up email with links to both the survey and the recording. This is a Zoom webinar, so your camera and microphone are off. The Q&A feature is working, so please enter any questions you have there. We will save time at the end for Q&A. We originally were scheduled till 1 o'clock, and our guests have agreed to stay on because we know there are going to be a lot of questions. We had nearly 300 people registered for this webinar. So we'll save time at the end to go through those questions. Emily Huff and I will work together to get them answered as best we can. So with us today are some individuals who play a variety of roles in New Hampshire's mental health crisis response system. We have Jenny O'Higgins, who's a senior policy analyst with the Division of Behavioral Health at DHHS. We also have Eric Eason. He is the account manager for New Hampshire Rapid Response Access Point at Beacon Health Options. We also have Heather McConaughey. She is a mobile crisis support specialist at Community Partners. And we have Detective Rochelle Jones, who is the community outreach coordinator at the Portsmouth Police Department. We welcome you all. Thank you for joining us. As folks know, we have a new crisis response system. It is now nationwide. 988 rolled out last month, and most of us are confused as to how it works. What number do we call, when, and why? So, Emily, I'll have you take down the slide, the opening slide, and we're going to start with our questions. And Jenny, I'm going to start with you. Can you just tell us your role and briefly share how 988 came to be and now how New Hampshire was already moving forward with this prior to the rollout last month?
Sure, yes, thanks, Michelle. So I'm Jenny O'Higgins. I work for the Department of Health and Human Services. I'm in the Division for Behavioral Health, and I work across all three of our bureaus. So we're looking to do some integrated care across substance use disorder and mental health throughout the entire lifespan. One of the things that I do is facilitate our 988 coalition. So we're bringing together stakeholders from Department of Justice and Safety, Department of Education, people with lived experience, peers, community mental health centers, on and on and on, our crisis call centers. We have a large group of stakeholders coming together to plan for 988. And the reason that came to be is at the federal level, legislation was passed that changed the 10-digit National Suicide Prevention Lifeline number over to a 3-digit easy to remember number. And the reason for that was to make sure that folks in crisis could remember a simple number to call, just like they do for 911. It's an imperfect sort of comparison to have 911 and 988 out there together, because you're not always going to get an in-person response for 988. It is a call line. But it's a nice way to think about having an easy number to remember when you're experiencing emotional distress, substance use, suicidality, really calling for any reason, regardless of diagnosis, to just have someone to talk to early. So because of that federal change in the national line, this number changing over, New Hampshire started to plan for what that would look like in our state. Prior to any of that federal legislation happening, New Hampshire had worked on a 10-year mental health plan, looking at what are the gaps in our system, and what are we doing really well, and how can we make sure that we have those pockets of excellence across the whole state? How can we serve people across the lifespan and across all of behavioral health really well? And so through the recommendations of that 10-year mental health plan and the Governor's Commission on Alcohol and Other Drugs plan, and some legislation in our state that required mobile crisis to serve children. All of those were sort of background drivers for us to launch a 24/7 centralized access point to be able to handle crisis call, text, and chat. And that access point would also be able to deploy mobile crisis teams throughout our whole state for those folks who did need an in-person response. And so the easiest way to think about it, since all of that is already a little bit complex, I think the easiest way to think about it is that there's this model out there that's best practice, and that's called Crisis Now. And the way that they describe it, that really helps me remember what we're driving towards as a state, is that everyone should have someone to call, someone to respond, and somewhere to go, right? And those are your three pillars of the Crisis Now model. What we're talking about today is that someone to call. For mostly, that's the bulk of what we're talking about. And we're going to get into a little bit about someone to respond, which is your mobile crisis teams, or when you need law enforcement, EMS, or fire, right? And we're going to talk a little bit about those things today, but that gives you a sense of the background and how we came to today that we have launched this new access point in New Hampshire back in January. And then with the changes coming at the national level, we're looking at how those things are the same and different and related.
Thanks for that, Jenny. You talked about Crisis Now. I know we have the links for Crisis Now. Emily can put those in the chat for folks. And thinking about those three pillars, so we have the call and respond, and then it's the stabilization after that will be a piece that comes along with that project eventually, Jenny, correct?
Yes, so New Hampshire is looking at what should crisis stabilization in our state look like. We do have location-based services. It's just that how crisis stabilization is defined, we don't quite have that in our state. But we do have some location-based services. And as you'll learn as we talk through what the access point can do, they also do have the ability to book some follow-up appointments at local community mental health centers to get that in person. So some of it would be mobile crisis teams, some of it would be connecting with your community mental health center. But the true third pillar defined in Crisis Now is a future vision for New Hampshire and not a piece of what's in place today.
Okay, great. Thank you for clarifying that. And Emily's put some resources into the chat for us. So, Jenny, when you and I talked, it's hard to figure out who's doing what around this project, and you clarified the state's role. So can you go ahead and share that with the folks here?
Sure. So the Department of Health and Human Services, took in all of this information and feedback to put out the 10-year mental health plan. And now we have the responsibility of working towards that future vision and implementing those recommendations for our system. How we do that is very administrative as far as what our role is. As administrators, we put out, competitive bids to figure out who is most qualified and able to do this work to the best of their ability in New Hampshire, right? So who could bring these things forward? So in terms of what we've set up in the system today, we have our community mental health center system, and we continue to work with them and to figure out funding models that will allow for them to have robust services. And that includes the addition of mobile crisis teams. In certain areas of the state, some have had mobile crisis teams for a few years, and in other areas of the state, they're brand new. But that's one piece that the department works closely with the community mental health centers who really do the direct service piece. And then we have a contract with Beacon Health Options that was through a competitive bid process. So we put out a request for proposals. Vendors apply for those requests for proposals, and we go through a process of determining who may be able to offer these services most robustly in our state. And that's Beacon Health Options that won the bid for the centralized access point with the ability to deploy mobile crisis teams. So they work very closely with the community mental health centers to make that happen.
So the state is the administrator, and then there are service providers that do the actual work.
Yes, our other responsibility is to monitor this work and make sure that we're all embarking on quality improvement long term. So when you start something is brand new, especially if it's really big and it involves a lot of culture shifts, it doesn't start out working perfectly.
So we had talked about that too, the monitoring and the quality, and then also advertising, educating, right? We can talk about that later in our discussion, but we want to come back around to those pieces for sure. Let's switch over to Eric. You've been the face of Beacon for many of us. And here in New Hampshire, can you explain your role and then define, we need a working definition of what crisis is, because calling 911 is very different than calling 988. So can you
Sure.
answer that for us?
Happy to. Yeah, it's been my pleasure, Michelle, to continue working with NAMI and the folks here in New Hampshire. My southern accent betrays that I'm not local or not from here originally, but I am local now, and I'm here locally because my job is to be sure that I am the face of the organization, that I'm out there helping folks understand this process, helping them understand what the systems are in place, and hearing when things don't work right so that we can take it back and make sure that we're addressing that and fixing things and improving things so that they do work the way that we want them. The concept of crisis is really pretty foundational to the way that we do our work. I get asked this a lot. What do you define as a crisis? And my answer to that is we don't. The person who is calling us gets to define that for themselves. And I often use a lot of analogies, but suffice it to say that the two different people in the same situation may react to that situation very differently. And while one person may feel like they're handling, the situation just fine on their own or with their existing supports and resources, another person may find that situation very overwhelming. And so if we try to define that externally, we might treat them both the same way, and they're not both having the same experience. So the easiest answer is that a crisis is self-defined. If you think that you're in crisis, we accept that you are, and we will provide you whatever support you need.
Great, thank you for that. Anyone have anything to add into that? Yeah, you did a really good job of explaining that, because I think people are unsure. Is what's going on a crisis for me? Should I call? Is it okay to call?
Yeah, and we encourage folks, if you're not sure, go ahead and call. We'll be happy to talk through, and then you can get a feel for what kind of services and supports we can offer you, and you can decide if that's the kind of services and support that you need. But that is our purpose here is to provide that service and that support to folks in, a variety of situations. And we do have a number of options at our disposal. So we might be able to get you to something that is very appropriate given your particular needs.
Great. So let's now talk about the details. So Eric, who's calling? Why are they calling? Which number should they call? These are all questions folks are having. So can you start us off with that?
I've been trying to think of the best way to describe this in my head because it's a very complicated question. Like, what is this? What is 988? What is the local, what is rapid response? So let me see if I can define things from a top-down perspective and help people understand it a little better. 988 is essentially a new name for an existing service called the National Suicide Prevention Lifeline. For many years, the number to reach that lifeline was 1-800-273-TALK. While that number remains in effect, there's now a new national 3-digit number, 988, which works similar to 911 in that you dial that number and you're connected to the network. Now, that word's very important. When we say 988, we're not talking about one call center somewhere in the nation where you've got a room full of people answering the phone. 988 is actually a network of local call centers. And I don't know the number of them, but there are in excess of 30, 40, 50 call centers around the country that are all a part of this network. Here in New Hampshire, there are actually 2 call centers that operate as a part of that network. One is Headrest, and one is the Rapid Response Access Point that we at Beacon operate. So when we began operating that service back in January, we developed the local number, which is the 833-710-6477 number that you see in the chat there. That is our local call center. That direct number continues to operate for people who want to call us directly. But understand that if you dial 988 here in New Hampshire, you will be connected to some call center somewhere, possibly here in New Hampshire or somewhere else in the country, who can provide you with the support that you might need in that moment. The question really boils down to what you feel is most appropriate, and honestly, in your situation, what you can best remember to do to get help. And so I want people to understand that there really is no wrong door there. So that's kind of the overall structure. And I know it's a bit of a plate of spaghetti, but it's about the best way that I can think to describe it. We can talk more about that to help people understand a little better. As far as who is answering the phone, obviously, because we're talking about a number of different call centers, you've got a slightly different mix of people from place to place. But here in New Hampshire, all of the people who answer phones for our crisis lines are people who have either who have experience either serving those in mental health crisis, or who may have lived experience in crisis, or perhaps both. We do have some people who have both lived experience and have been service providers for people in crisis. So all of the people answering the phones and the texts and the chats all have that level of expertise and experience. And they bring that experience to bear in providing support to folks, helping them helping us talk through that with folks and understand what their needs are, what their concerns are, and then helping them understand what their local options might be. That could be a variety of things that we've kind of touched on already. Some services that we might link them to locally in the community. We could, if the need arose, link them to other services such as 911, law enforcement, fire, EMS, things like that. But we do a really good job of generally being able to support folks on the line by really doing nothing more than providing that warm support and helping them work through their problems with that work on the phone.
So you said that it isn't a licensed clinician necessarily that you're going to talk to on the phone.
Not necessarily. We have some who are licensed clinicians, and there are always licensed clinicians available in case their expertise is needed. So even if you're on the line with someone who isn't a licensed clinician, if they feel that they need to involve a clinician, they can. We have ways of networking with each other while we're on the job and getting support and having them offer their expertise as well. But what we find is that level of expertise is usually not needed, because really someone in a crisis, what they need more than anything is a connection. And the best way to make a connection is generally to understand what it's like to be on the other end of the line, right? That's why we find that people with lived experience tend to do this work really, really well.
Can you just talk about the training that folks get in order to staff the line?
Sure. We do take them through a number of trainings. There's about 2 weeks worth of classroom training and then some additional weeks of it's the kind of see one, do one, teach one model that you think of in the hospital, where you work under supervision, you work alongside someone, and then you kind of demonstrate that you're able to do the work. But we train folks in a variety of things. Of course, there's the basics of how to operate the phone system, how to manage the software, and how to document. But there's a lot of work that we do with how to meet someone where they are, how to provide non-judgmental support, how to really understand the right ways to ask questions in a way that make people understand you're very interested. We call them open-ended questions. I myself am a clinician, and that's the way that we discuss them. But that just means that we're asking questions in a way that invites collaboration. It invites people to share information. It doesn't feel pushy. It doesn't feel like we're being accusatory in any way. We're genuinely interested in trying to understand what's going on and exploring that and letting the person who made the call lead that encounter so that they're the ones making the decisions for themselves. That's ultimately our goal, is to lead people to making the best choice for themselves. We don't believe in forcing choice upon people unless we just feel like there's absolutely no alternative there, unless the person is not joining with us in some way on the call.
Right. That will take us into our 911 portion, because there are times when we do need to take it further, right?
Sometimes.
Yeah, sometimes that does happen. So can you give an example when someone calls, Eric? What's that going to look like for the person who's placing that call? What information is going to be gathered?
Sure. I can speak for what happens when they reach the beacon answer point. Understand that the experience might vary a little if you reach a different answer point. So depending on how you access the system, mileage may vary, we'll say. But when our staff answer the call, we will need some basic information like your name and your phone number and possibly your address, things like that, just so that we've established where you are in case we get disconnected, we could reach back out to you. Understand that any of the information that we ask is optional. You don't have to give your name, or you could give a fake name. You don't have to give your number. You could give a fake number. That might handicap us later if we're trying to get back in touch, but it's really, again, your choice about what you feel comfortable to share. We'll just ask you, how can I help you? What's going on today? What is it that you need help with? And we'll listen, and we'll let you lead that conversation. And we will ask the questions that we feel at any given point help us kind of steer our own decision making in what might be a good service for you. So again, we really rely on the caller themselves to define that experience for themselves in the large part.
Great, thank you for that. Folks are concerned when they call that there could be call tracing. Does that happen at all, Eric?
We don't have the ability to do that. It's not possible. So if you don't give us a phone number, we don't know your phone number. The only exception to that is that if you text us, the text does share your phone number. So if you're contacting us via text, your number does come through because that's how text messages work. However, if you're chatting, it doesn't give us your location. If you're on the phone, it doesn't give us your location. And to be fair, having your phone number doesn't give us your location. It just gives us your phone number. And we don't have the ability to then turn around and trace that number. We don't have that capacity in our call center.
So can we talk about geolocation a little bit?
Sure. The only way that we integrate geolocation in any way is that if a person has agreed to receive mobile crisis services, which does happen pretty frequently, then we will ask them for an address to which they need the team dispatched. That doesn't necessarily have to be their home address. It could be an alternative meeting location. Maybe they want to meet at I always want to say Waffle House. That's how Southern I am. Maybe they want to meet at the McDonald's down the street, and that's fine. And so we will input that address into the system, and then use that address to locate a team on our geolocated map that is closest. So the geolocation is really more on our side of things to match with the address that the caller provides voluntarily, whatever that address may be. So we're not pinging your location, so to speak. We can't pick you up on a map, or we don't see your little dot moving around. The information we have about your location is what you provide us, and that remains static unless you update us.
So this is different than 911.
It is, yes, it is.
So folks need to know that because there's concerns about people having access to location and information. And so you're telling us that's not the case.
That is not the case. Now, that has been a much larger national conversation, and I will acknowledge that conversation is occurring. I will also acknowledge that there could be a change in the future. I don't know that, but as of right now, it is deeply ingrained in culture of the National Suicide Prevention Lifeline that we do not geolocate, because we want to help people understand that they have an option to receive services and not be subject to that kind of tracking and tracing.
So
Go ahead, please, Jenny.
I just want to jump in I think Eric continues to say, and I just want to reiterate too, that the primary goal of the Lifeline and of New Hampshire Rapid Response is to provide support for people in emotional distress when they need it most. And everything they do is person-centered, so based in choices and really meant to provide care in the least restrictive way possible, right? So the National Suicide Prevention Lifeline has always tracked some data around if any of the Lifeline calls require a connection to emergency services like 911. Currently, fewer than 2% of Lifeline calls do require that connection back to 911. And while there may be safety and health issues on a phone call that may warrant a response from law enforcement or emergency medical services, and the 988 coordinated response with 911 is intended to promote that stabilization and care for that individual, but again, in the least restrictive manner possible.
Thank you, Jenny. And I just want to clarify terms here because we're throwing out the term Lifeline and New Hampshire Rapid Response. Eric, can you just clarify New Hampshire Rapid Response versus New Hampshire Rapid Response Access Point? Semantics here, but what does that mean?
It is semantics. When I say New Hampshire Rapid Response, I'm talking very specifically about the teams that respond in the community, the mobile teams. And when I say the Rapid Response Access Point, that's our service, the contact center, where we answer phone calls, text messages, and chats.
And go
We
ahead.
think of that, Michelle, as a full system. So when we say New Hampshire Rapid Response, we mean the access point that does call, text, chat, and we mean the mobile crisis teams that can respond in person.
Okay. Okay, great. And when you're talking about the Lifeline, Jenny, versus the Rapid Response Access Point.
Yep.
Can we get clarification around that? Eric too had talked about 988 and the Lifeline being one and the same. Is that correct?
So 988 is the crisis, the suicide and crisis lifeline that is a national response. So this national resource, the National Suicide Prevention Lifeline, has been in existence with a coordinated network of 200 centers across the country for 35 years. That lifeline number was 10 digits. It has collapsed the network into the 3-digit number to be easier to remember, to help people in crisis have easier access to those services. It's a national resource. And in New Hampshire, part of our planning is to work to make sure that when calls are answered by New Hampshire centers, they get the same services. Our New Hampshire folks can get the same services that you could if you called Rapid Response, whether Headrest in Lebanon answers that call or whether Beacon Health Options answers that call. We want New Hampshire folks to have access to the enhanced services, meaning mobile crisis or local follow-up appointments with your community mental health center. However, because 988 suicide crisis lifeline is a national resource, there are some challenges in how calls are routed that mean not every call may get a New Hampshire based center. And that's where it becomes more confusing, and we continue to get into some of the clarity of that. If you call Rapid Response or you call 988, you are getting a connection to a trained counselor who is there to help you in that emotional distress. There, you can't go wrong making the phone call. Our only clarification is around if you don't get a New Hampshire-based center, can you get a mobile team if that's what you were calling for? And that's the vast majority of calls aren't going to need that. You're going to need someone to talk to.
And you said trained counselor. Can I just clarify? It's a trained individual that you're going to get if you call either of those numbers.
Yes, the
Okay.
national language, sorry, I know there's so many language differences,
Yeah.
right? And so Eric has already described to you who answers the phone. The national language and the lifeline, they use the word trained counselor, but that does not mean like master's level clinician or anything in particular. It means an individual with crisis call training.
So when we're talking 988 and Lifeline, we're talking a national program.
Yep.
Right? When we're talking Rapid Response Access Point, we're talking New Hampshire.
Yes, the one distinction is that the national network has New Hampshire-based centers. So as a part of your national network, you have Headrest that's sitting in New Hampshire. You have Beacon that are either sitting in New Hampshire or New Hampshire trained folks. And so the national network has call centers that are in our state that can still provide our in-state enhanced services. It's just the complications of national routing today that mean that we can't say 100% of calls that come from New Hampshire will be answered in New Hampshire. And part of that is because the routing is all based on area code. And so you're routed, if you're calling from a 603 area code, you're very likely to be connected with a New Hampshire center. But if you're in New Hampshire and you're calling from a cell phone with an area code of another state, you will be routed to the crisis center of that state. So if I call from my Arizona exchange, I will get an Arizona call center.
Okay, so let's try to tease this out for folks. If I have a sister in California who's experiencing a mental health crisis, but I'm here in New Hampshire, can I call who do I call?
You can call 988 and you can call Rapid Response too for your own emotional distress. This is the reason that we kind of just say making a call. You can't go wrong with having someone to talk to. The concern is if you need in-person services, but the Lifeline, as I said, has been in existence for 35 years. They have always taken the calls they received. If their caller is in Hawaii or Alaska or wherever, they sit with that person and they look for the resources that they need, right? And that will still be true today. I think what we're trying so desperately in New Hampshire to get clarity around is that we've been talking a lot about the new, mobile crisis teams. And if you're looking to get someone out to your home, or the crisis that you or your family member is experiencing really warrants having someone come to you in person, that's where we're saying that calling rapid response gives you access to that every time.
So just to clarify, so we have rapid response access point and headrest, both answering calls for folks in New Hampshire. Are they also taking calls that come in from through the 988 number? People may be calling from other states and get bounced to an operator in New Hampshire or
So
yeah.
all of that, yes, those are our two centers that answer Lifeline calls through 988. They're part of the national network, and all calls are routed by area code of your phone number. So when you call from a 603 number, you're first routed to New Hampshire call centers. Your backup is also a New Hampshire-based call center. So if they're unable to answer the phone within a short period of time, they bounce the call because they want all the calls to be answered quickly. So they will, your first two options are Beacon and Headrest right here in your state. And the same is true for every other state. If you're sitting in California and you're calling 988, you're getting a California-based center first. If they're unable to answer, you do go to a national backup. The good news is the phone gets answered every time, and everyone has great training.
So never a busy signal, never on hold?
No, they answer the phone within the first, I think the performance indicator is 20 seconds.
Yes, there is. I will say, and Jenny, not to contradict, but I will say that the way that the routing works is in times of high call volume, they could pin the call with a call center for several minutes while they await an answer. And then if it doesn't answer, it rolls to the next one. So there could potentially, if there's a really high call volume at a given time, it could sit in a queue for just a couple minutes while they await a call agent to answer. But then if not, it will roll to the next one. It's not happening very often, but it is possible. I do want to be clear about that.
And so if a call does get picked up by an operator outside of New Hampshire, either because there was high call volume and I got bounced, or I'm in New Hampshire, but I have an Arizona area code, can I still get back to New Hampshire to get help here?
It's a little complicated. There is a mechanism to transfer nationally from one call center to another based on area code, which is how that transfer would happen. However, there also are policies in place, and because there are certain best practice expectations that a person in crisis is really not in the best place to be bounced from one person to another. And so there are limitations placed by the NSPL around when it's appropriate to transfer someone. And generally they say that when a person is actively in crisis, that's not the time to transfer a caller. So it'll be a bit of a judgment call on the part of the person who's answered the phone and who's providing support. And it may be the case that they feel that transferring to get local resources might be appropriate. But again, it will be a judgment call based on the specific scenario.
Okay. So, if I have concerns, call any of those numbers. 988, the 1-833-710 number, right, that we have in the chat. And if things have escalated and you recognize that more help is needed than just a conversation, as we've talked about, text, chat, or a call often will resolve whatever the issue is. And we should talk a little bit about appointments because you end up giving appointments to people. Yeah, then mobile crisis comes in, right? So can we talk a little bit about that? And can you talk about if someone's affiliated with a community mental health center or not, what that looks like?
Sure. So when we start thinking about resources, when we're having a conversation with anyone in crisis, we're doing an assessment of not only what their immediate concerns are, what the things are that they're struggling with, but also what their available resources are. And that includes the people and the agencies and the material resources that they have who can provide support or that are available for support. So in other words, that would be an understanding of, do you have an existing provider? If not, does there happen to be a provider in your area that might be able to help you now or according to your acuity in the very near future? Do you have a family member, a friend, a trusted loved one, someone who can help you get from here to wherever you need to be, or who can support you in the moment while you await help? So we do, and even like, do you have transportation to get where you need to go? Those are all things we have to think about when we're making an appropriate treatment decision. And so all of those factors really influence what we do. Now, ultimately, the person gets to decide for themselves, but based on that information, we will say, well, given this circumstance and that, and given your availability of this thing or that thing, we suggest that you might consider this service. When we think about services, we can do a number of things. Obviously, we're providing a service just by talking to folks and supporting them and helping them think through things. Often that's enough. And that's really about 75% of the time or more. That's all that people need, is to just call us and to talk through things and to understand and kind of think through what's going on and come up with a plan for themselves that they're able to use their own resources to manage. Maybe they're going to reconnect with an existing provider. Maybe they're going to give a friend a call and have them come over and be some support. That's really what they need right now. However, in some cases, they do need something a little more. And that's when we start exploring some of those alternatives like mobile crisis or a same day or next day appointment referral. So we do have the ability to do both of those things with the local community mental health centers, which cover the entire state. So there is statewide coverage for mobile crisis. There's statewide access for same day, next day appointments. And we're able to, based on, the address that folks are providing, to tell them what their local agency might be, or to find a local team to respond for their crisis. When we think about which of those is most appropriate, again, it depends on a variety of factors, but one thing we need to consider is, how significant are your concerns at this moment? Do you have the capacity to wait for a little while for someone to show up? Or do you have the capacity even to wait for a little longer to possibly make it to an appointment tomorrow? That's very individualized. It's a very individualized decision that needs to be made. And then we're able to make the appropriate referral based on that. Again, we try really hard to keep people out of the ER and to keep people from having to engage with 911. And so I think it's around, like Jenny said, about 2% or less are we engaging with 911. We're also sending people to the ERs in a very limited capacity. And generally when we do, it's only because their capacity to remain safe in their current situation is just not there. They're really not in a place where they feel like they can wait for mobile to come show up, or they're not able to wait for that appointment to get there the next day.
And Eric, when you're talking about those next day appointments, is that whether you are receiving services at the community mental health center or not?
It is available to anyone.
Okay.
Yes.
Okay, great. So this sounds like an art form as much as it is a science.
There's a bit of art to it, yes.
Right, right. And 911 seems to be more clear cut. This is a different system, a new system. And I think that's part of what we're talking about here. We're trying to develop this system. So there have been changes as we've gone along. Eric, can you say, you turn things over to mobile crisis? Can you say what that looks like on Beacon's end? You've decided, sure. Whoever has taken the call says, yes, we're going to need to deploy or send out a mobile crisis response team, which is now statewide, right? We have teams statewide. Can you say on the call center's end what that looks like? And then we'll go over to Heather.
Yeah, absolutely. We have an electronic documentation tool that we're typing notes as we're chatting on the phone or via text or whatever. And we will generate that report, and we will go into our dispatching system, locate the available team that's closest to that person's location, send that information to them, and let them know that there's a person in distress who is asking for mobile crisis dispatch. And then at that point, the team has a way of acknowledging and accepting that dispatch so that we can confirm on our end that that has been handed to them. So we're not just sending it out to the universe and saying, hey, somebody should be giving you a call. we're actually waiting to get that confirmation back that yes, indeed, Heather at Community Partners maybe has said, I've got this dispatch, I'm going to be picking it up and acting on it. And then that's handed off to the mental health center. If we don't get that confirmation, we'll move along and look for another team that might be available, which may not be quite as close, but hopefully still close enough to respond. And we do have certain processes in place that if for some reason it's very busy, or I don't know, there's something unusual and there's just not a team available locally, we can talk about possibly having a team engage from further away but via telehealth. Or if that's also not an option, then we might discuss if an ER or next day appointment is more appropriate in that situation.
Great, thank you for that. So now Heather would be the team receiving that call to be deployed out to a crisis situation. So Heather, can you tell us who you are and your role at Community Partners?
Yes, so I am an intentional peer support specialist on the mobile crisis team for Community Partners. So I am part of the team that is handling these dispatches, also these rapid access appointments, and then doing follow-up with these people if they would like it. And so like Eric said, he'll send the dispatch through that system that we use, and we'll accept it. We get like details about the call on Beacon's end. And then one of us will make an outreach call to the person that's in crisis and introduce ourselves and just kind of talk a little bit about what's going on, let them know that they can expect us to arrive in about how long, and then we will show up.
Can you tell us what kind of calls are coming in? Who's calling? Who are you going out for, and where are you going to?
We're getting a lot of different calls. It's really anyone. It's people across the lifespan, people that have been longtime consumers of the mental health system, people that are new and looking for services. Maybe they've been looking for services for a while and they've been waitlisted, and things have maybe escalated for them and they're needing support in the moment. And in terms of where we're going to all different kinds of locations. We have what's called secured locations and unsecured locations. Secured location is going to be something like a school, a hospital, a police department, something where there's other people there. It's like a safety thing. And then an unsecured location is going to be like somebody's home or somewhere out in the community, maybe where there's not, other people.
Thank you for that. When you and I were talking about your role and what mobile crisis does, you talked about the attitude that you approach situations with, because I think what we're hearing with this system is there's a lot of concern. There's concern about confidentiality. There's concern about safety. There's concern about getting your needs met. There's concern about incarceration. How do you all approach situations with mobile crisis?
Absolutely. So we really try to go into every call looking at the caller as credible, capable, intuitive, and able to collaborate. So it's very much like avoiding coercive measures, safe decision-making and trying to minimize iatrogenic harm, which I'm sure we all know is unintended consequences that happen as a result of decisions that providers make in the course of treatment. And so it's really more of an attitude of like working with the person rather than doing for them, if that makes sense.
Right. And so iatrogenic harm, that's harm that we inflict in the process of trying to help someone. We actually create more harm. And I think when we're looking at this 988 system, what we know is this could be the first time that someone's actually reaching out for mental health help. Right. So it's important that the outcomes be positive. Right. And so this training that you got, can you tell us where that training came from?
Yeah, so I believe it's administered by the state. It's the Rapid Response Access Point Core Training. And so I think there's about 18 hours. It's 3 different 6-hour sessions. And then there's a whole bunch of other trainings. There's like 40 plus hours of training that we do just for this system. And those 3 trainings were awesome. I really enjoyed them. It was very much akin to, I'm so sorry.
That's okay.
It was very much the things that were presented in this training were, in my opinion, very much akin to the values that intentional peer support already encompasses. And so I was really excited to be seeing these concepts presented to people that are in other roles besides peer support clinicians, other providers, whatever. And it was really about just like, shifting that focus from what we've always done, and just being, I don't know, I guess just being like differentiating from being IEA focused to like treatment focused.
Right, right. So avoiding iatrogenic harm. We don't want to create harm. We want to help people.
Yes, absolutely. And really not really trying to avoid employing coercive measures like wherever possible.
And I don't think you touched on the van. Heather, can you
The
talk a little bit
van.
about that? Because
Yeah, absolutely.
Yeah.
So our team was fortunate enough to get an awesome van, and that is to take on dispatches. When we go to unsecured locations, we've had a couple of situations come up where maybe the person is homeless. I think we had a situation come up where their apartment was very small and they just had like a lot of stuff, and there was nowhere to actually like talk to this person and try to support them. So we got this wonderful van that's equipped with like, plugs and like Wi-Fi and all this stuff so that we can bring them to dispatches and we have a place to have these appointments if the person doesn't have a good place to talk.
Right, great. So we're moving forward with this and we're being smart about it.
Yeah,
Yeah.
really thinking outside the box and presenting people with options. I really appreciate all of the options, the alternatives to the hospital. It really helps us meet people where they're at.
Right, and take good care of them.
Yeah.
Yeah. And then mobile crisis doesn't always work. And sometimes 911 is the only option. So we're going to turn it over to Rochelle. Actually, let me go back to Jenny. Can you explain, Jenny, what circumstances are when 911 is going to be necessary?
Sure. So, I mean, as a community member, when do we need to call 911? We need to
Yeah.
call 911 when we need police, fire, or EMS on the scene, right? So if we need medical services, if we need firefighters, or if we need law enforcement because of a medical emergency or crime or issues with violence and safety, those are the appropriate reasons to continue to call for emergency services, right? And these other services are meant to get you the care you need when and where you need it for emotional distress and for, having thoughts and feelings of suicide, for, substance misuse. These are the kinds of reasons that you might call these other services, right? And right now, I think we've been calling 911 because there hasn't been somewhere else to call, not because it's necessarily the best, care that for those particular mental health related challenges. And so I think our first responders have needed to go out for a lot of reasons that they weren't necessarily trained for. And just like we wouldn't want to respond to crime or a fire without training, right? So we're trying to work in close partnership because we're trying to get to a place where we've got the right teams for the right situation that are trained and ready to handle that situation. So as a community member, I would think you'd want to call, 988 or rapid response for that emotional distress, whether it's for yourself or a family member. I think that what you would want to continue to call 911 when you need EMS, police, or fire, and that will remain appropriate in circumstances where it may be a behavioral health need, but it's escalated to a situation where someone's life is at risk, and you still may need an emergency response. And as we've talked through, even the in-person responses of the behavioral health system, mobile crisis is meant to get to you within an hour. And sometimes in crisis, seconds is too long. You still need 911. In those circumstances where seconds would take too long, you need to dial 911. And so there are still going to be times too when rapid response or 988 lifeline is talking to a person or a family member, and they realize that there's imminent risk for themselves or others. And it is a rescue line. And that is when we need our partnership with 911 to send for that rescue.
And so that's a great segue into Rochelle. So Rochelle, can you tell us who you are and your role at the Portsmouth Police Department?
Of course. I'm the community outreach coordinator at our police department. So I do a lot of building relationships with the public and creating outreach programs. And, I'm the liaison to a lot of different agencies and support services. So I'm the liaison to Seacoast Mental Health. I'm the liaison to our recovery, DCYF, also for, I was a school resource officer. So that there's a lot of just all that community connection. And so we really try to have programs and reach out to people in conversations before there's an emergency. So the first time that they have to call us, or when they do call us in crisis, it's not the first time they're seeing us, and there's some familiarity there and there's a connection there. But a lot of times we are certainly seeing that people still call 911. And I think sometimes it is because they don't know what to do.
Right.
This is still new and they're learning. So whenever somebody is not sure about what to do and there's any type of crisis, even if it's a, squirrel, stuck somewhere, it's like they're going to call 911 because it's been so ingrained in
Right.
us since we were little. And so what we have been seeing personally at our department, and we love it. We love having this option. I can't stress that enough. And police officers in general, because of some of the reasons that you already talked about. But, we were left with limited options a lot of times. We show up and we're really just asking somebody or determining through our training and experience, is this a situation where we can offer somebody is saying that they're going to do some self-harm, and we'll ask them, do you want to go to the hospital and talk to someone? And that's really kind of been our choice or our offer. And if somebody says absolutely not, and we decide it's a situation where you absolutely kind of have to, we can't leave you. If we leave you, we're not comfortable with that because of what we're now observing, then we would have to take them in an involuntary emergency admission,
So
to
Rochelle,
be
can we
evaluated at the hospital. And that obviously requires, a lot of paperwork. Yep.
Can
Oh.
we switch over now to back in May, what happened? So we can talk about your 911 deployment?
Oh, sure.
Yeah, that
Yeah.
was made in the Portsmouth area. You ultimately ended up being the officer who interacted with an individual supported by a very large team. So can you tell us what happened and how you were able to resolve that in a positive way?
Sure. And I just also want to say too that we're thankful because we've been making a lot of, we're seeing it as more referrals for 988 as well. So when people do calls, we say, okay, next time this happened, like you definitely want to use this number. Or if it's people that we repetitive see a lot of times, that we'll know kind of what the situation might be, and we'll call 988 as well. So we appreciate it. So one of my responsibilities, I recently joined our Seacoast Emergency Response Team, which is a tactical SWAT team, but also we have a team on there that's for crisis negotiations. I have been through crisis intervention training as well, and a lot of other specialized trainings. And I don't know if some point later you want to ask about, or people want to know about how police are trained now. It's a lot different than when I started as far as base training for mental health and recovery. I'm a recovery coach as well. I went through that training. So I just joined the emergency response team, and a little bit about crisis negotiations is it is very similar to what some people were already talking about. Just about asking questions, like Eric was saying, and non-judgmental, just trying to build a connection with somebody. So it's very different than what people think police interviewing is, where we're usually asking a lot of questions to get answers to solve crimes. So why are you here? What are you doing? And that's the opposite. It's really just to get somebody talking and about what's going on in their crisis. And, we're supporting them and trying to help them find a good, safe solution to this. So I had just gone to a training and for crisis negotiation, and one of parts of the training was actually, somebody talking about this particular situation that came up. So I was not called to this because I'm a negotiator. What happened, but there was a gentleman who was in an unsafe place physically and mentally, that there was a big concern about, and it was not in Portsmouth where we are, is in a neighboring city. So the officers that had been on scene had been trying to connect with this person for about 3 hours and didn't believe that they weren't getting anywhere. And he was pretty upset, and he was actually requesting an officer that he believed had some commonalities. Like, I want to talk to this type of officer, which is, to me, is a green light about somebody is basically asking for a connection. I want somebody that I can relate to, is kind of how that translates to me. I didn't know anything about this person other than what the officers believed that his name was. And so I went to the location, and I was my human self, where I just kind of introduced myself and said, I'm officer, well, I didn't even say officer. I just said, I'm Rochelle. I'm Rochelle from, Portsmouth Police. And you asked for somebody like me, and here I am. And, and I quickly kind of just went to what's going on? Like, what's going on? How did you get here? What happened? And it was a situation where there was a lot of other police officers, but there was kind of a barrier where he wasn't able to see that. So if I kind of made myself in a position, he could just see me and concentrate on me. It was very distracting, and what I was seeing in behavior was pretty consistent with schizophrenia, what I've been taught. And so I received a really amazing training from NAMI, and also from basically from NAMI years ago, that always resonated with me. If people are experiencing that, there can be many voices being heard at once. And so I knew it was very important for him to just be able to concentrate on me and my voice. And it was very important for me to close out the other chaos and just set the tone of, we're going to have a conversation. Because when I got there, the big major request was, we need him, out of this unsafe situation that he's in. And I stopped that and said, I'm just going to talk to this person, and it takes what it takes, and you do what you need to do in the meantime. But I didn't want him to experience my anxiety, which I was really afraid. So, I just tuned everything out, and I just talked to this person and met him in his reality, connected. We didn't talk exactly about self-harm or any of that came up. It was just all the other frustrations that were going on. I de-escalated myself. I tried to de-escalate him just by showing that everything was about this person in that moment. I didn't care about what else was going on. I cared about him. And I explained who I was and what my position was. So there was no concern that I was going to harm this person. We talked about what school we went to. We talked about people in the community that we knew. I validated his anger and frustration and concerns. I would be upset about that too, and I was empathetic. I reflected, the statement so that he understood that I was absolutely listening to him. And at one point, like, I think I offered water, and he didn't want any water, and then, I noticed that he was smoking cigarettes. And so I'd asked, the other officers, I said, well, it looks like he's smoking cigarettes. Like, that could be a good thing. That could be a connecting thing here. And I said, how are we getting these cigarettes, to this person? It's kind of like they've been throwing them down to where, this person was. And so I asked another officer to hold on to me, and I said, I want to try to hand this cigarette to this person. I want to, hand it to him. No offense to anybody else. He was not friendly when I came up. He was difficult and it was challenging, but I was determined to connect with him, and I didn't care. Like, I was just non-judgmental about, and I think he saw that. I think people can absolutely tell when, you're just trying to say something to get them to do something and you can't, right? It's like they can sense it and they can see it. You have to be genuine in your connection with someone. So, I asked him, do you want a cigarette? And he said, yeah. So sure. So I got a cigarette, and I had another officer hold on to me, and I just leaned as close to him as I could. And part of that was my safety. And the other part of it is I really didn't know how he was going to react. If he was going to grab me, was he going to hit me, So I wanted somebody to hold on to me. Like I said, he was angry. And so when I reached down to give him that cigarette, and he had to kind of move to get closer to me, and just kind of, took the cigarette out of my hand very gently, and we looked each other straight in the eye, and we were face to face. There was no uniform, there was no what you're wearing. It was just, we were two humans, looking at each other. And that was where things took a turn. And so I just continued to offer guidance, you know, and offer some suggestions. At the point I was like, we really can't be here forever. And, you know, I'd really like to see you, you know, resolve this on your own terms. And, you know, and I promised him that we would do this together and that I wouldn't leave him, you know, and then he did, he came up to a safe area, and he actually walked to my cruiser and tried to put himself in my car, which was amazing because he was afraid. And he said, listen, like, you know, I think, you know, the police officer is going to hurt me. I think they're going to jump me, you know. And I said to the other officers, we're not going to do that. Right. And I said back to him, I said, they're telling me that that's not going to happen. And I'm not going to let that happen. We're going to do this together, you know, and we did. And he got in the cruiser, and, you know, and I told him, like, I have to take you to be evaluated. You know, everybody knew that this was going to take as long as it took, and everybody knew, and even the, you know, the supervisors in charge knew that this was not going to be, you know, a criminal arrest. Like, this person needs help, you know, so how do we get them there? And how do we do that safely? And so, you know, we just agreed that I would have somebody else in the car with me because I didn't want to put him in handcuffs either. He was being cooperative. You don't get more cooperative than putting yourself in somebody's police cruiser, right? And so I was able to bring him to the hospital, and he had a request. There was a certain hospital that he said he's absolutely not going to. Like, I hate, you know, and I said, okay, I will not take you there, you know, but I do have to take you somewhere. So let's go, you know, to another hospital. And we did. And when we got to the hospital, before we went inside, like, he get out and, you know, we hugged. And then I walked with him and waited for his intake, and, you know, and sat next to him, and, you know, waited for him to tell me that I could go back to work. You know, I said, I'll stay with you as long as you want me to, or I can go back to work. And, you know, and he looked at me and he just said, thank you, you know, and I looked at him and I said, no, thank you. Thank you for trusting me, you know, and so we have been in contact a few times after that, but not so much right now. But, you know, it was not what I was expecting when I went to work that day. And I was just very thankful to be able to have that connection, to have had, I can't emphasize enough, all of the trainings and support over the years, and, you know, with NAMI and just, you know, crisis intervention and these things. And so I also get to go around now, and I will be teaching about this and how I built that connection with this person, and how we both, you know, connected for other officers, which is very important to me. You have to be vulnerable, like, you know, and what I found in my career, I've been with Portsmouth for 20 years, but I started working with incarcerated people for 5 years before I became a police officer. And I'm born and raised in Portsmouth, and, you know, I've seen my friends go through mental health, like, you know, and family, and we're all touched by it. But what I found is I may not experience the same thing that somebody else experiences, but we can connect on emotion. So I didn't try and say, you know, hey, like, I know what that's like. I totally understand. I would just say, I know what it's like. You know, he was very upset about feeling discriminated against. And I said, I know what it's like to be discriminated against. I know what that feels like, right? Not only am I female, but, you know, I'm a person of color, or I'm this, or I'm a police officer. Sometimes we get, you know, and it's just knowing that you could share that. And I think that was comforting, you know, and I wasn't judgmental, and I had no intention of being, you know, that they were in crisis. People are in crisis. Crisis looks different for everybody, and it's not for me to judge, and it's not for me to try and put myself in their shoes. You know, it's just to meet on common ground. And how do I get you to the professionals that are going to get you the continued help that you need?
We need each other,
We do.
right? Right. So the crisis system needs 911 responders. We need law enforcement. We need them to show up in a compassionate and trained way. This is about connection. It's about relationships. It's about collaboration. Eric, can you tell us, police officers, if they're in a crisis and they need support, can they call 988? Do they call the 833 number?
They certainly can. We've actually coached them to call the 833 number. There's been some conversation. I've been kind of trying to be in the chat, so I apologize if I'm a little out of the loop. But there have been a lot of discussion around routing and how area code impacts that. And so we've coached law enforcement to call the 833-710-6477 number, because regardless of what number you're calling from, if you call that number, you'll get the access point every time. And that way they're called. But yes, they are calling us at that number, letting us know they're law enforcement. We've got a kind of truncated process that we follow to be sure that we're answering and processing those calls as rapidly as we can, and we will get a team out to them or let them know, if there's any issue with getting a team to them, and they'll know that within a few minutes.
Right, and I would just say on the heels of that, I recently went to the FBI school for crisis negotiations, and that was a conversation too, where there was officers that were there that had to go and respond and had rapid response for another officer that was contemplating some self-harm, and just, with the trauma, I think Michelle and I talked about this already, but it was a successful situation that day because, we saved the life. And there's officers that do what I did every day, but in many, many times during the day, when we talk about the vicarious trauma. And even though that moment was successful, I don't think I realized the gravity of it until a couple of days later, where I went, why am I having these feelings? And I connected with another officer who had a similar incident, but it has prompted, and I'll probably reach out to you folks in the future to make sure that we have crisis intervention teams, but everything's really big, but it's the little things that do add up. And that's what I find when I interact with people. There wasn't one big thing that happened. These are little things that have continued over the years that haven't been resolved, or it's one more little thing that gets that ball rolling. And so it's very important to take care of those little things as well.
This system is for all of us. It isn't just for those people, it's for all of us. Every one of us might need this system at some point in time. That leads me back to you, Jenny. Improvements to the system. We're creating a system here. When you're creating something, sometimes tweaking is needed. And we know that people need to collaborate and let us know how things are working and what could use improvement.
Yeah, of course. I mean, we can't build a system and improve it without people with lived experience talking to us and letting us know how they experienced calling 988 or rapid response, how their family members felt when mobile crisis teams came. Did they never show up? I mean, the same with our first responders. If they're calling and they want a mobile deployment and it doesn't work out how they wished it worked out, I think some of it is going to be that we can't get there in seconds or minutes, like I talked about, and that will continue to be a frustration for folks who really want someone on scene quickly. I think that's still a huge improvement over going to an emergency room and waiting hours or days if we can, have someone to talk to immediately. But I think you can, at the same time that you can celebrate that the system's improving, you can also continuously say we need more, or we need to improve it further, it needs to be better, or it didn't meet my needs. We know already that it's difficult to get language services. It's difficult to have someone who truly understands, trauma of military veterans, or, a youth experience when it's an adult who's answering a call. All of these kinds of pieces where we'd like to have a foundation of equity, and we need to get there. We also, though, need to continuously monitor and hear from people about their current experience of the line and keep making it better and better, right? And I think it really does. I think you were just connecting on how all of us are a part of humanity and we all need each other, and it's completely collaborative. I don't think we can build the system that we want if people won't tell us how it's going, and if the partnerships weren't in place so we could work together to figure out how to do it better. And when we have workforce shortages and we're worried and concerned about the capacity of our behavioral health system, how do we think creatively to train up a peer workforce or community members to support one another, right? So I think there's a long way to go still, even though we're proud that we're getting there. And I would encourage people to make sure they share their experiences.
Even between agencies like law enforcement, so police, mobile crisis, if there was a miss somehow in an event, for them to pick up the phone and call one another, Jenny?
Yes, I mean, so much of this is individualized. So each caller, I mean, I think Eric spoke to this earlier, that two people could even be having the same challenge and not experiencing it in the same way. And that's going to be true about everyone having sort of different histories as well. So I might be impacted by something because of a trauma that I experienced, and you don't know that when I'm calling. And so if you experience the same thing as me, you would handle it very differently, right? But for me, this is very traumatic and it's triggering. And so I think just in the same way that we would make sure that every response is person-centered, we have to think about that with each other's relationships as stakeholders and departments. I have very different history of training and my professional background than Rochelle, right? I don't know what it means to be in law enforcement. And so how we speak to each other, we're not always going to relate immediately either. And so I think that it's a lot of building a system together is giving one another grace, getting to know one another, and we have to actually talk to get it right, right? So it has to be that when something doesn't go well, that we don't say, I'm never using that again. Instead, we say, how can I be a part of the solution to make it better for my state? Right? So I'm going to call the police department that the interaction wasn't right. I'm going to call, the call center. I'm going to call the community mental health center. I'm going to notify the state in whatever way makes sense for you to resolve that. I think the most encouraging part in my role in seeing that the 988 Coalition work together, or in working with Rapid Response and the community mental health centers, has been that everyone is so willing to keep working at it. That's the encouraging piece. That's the piece that gives me a lot of hope for our system. We have a lot of people who want to get it right, and who all have, for the most part, some amount of personal experience of their own of why they want to get it right, right? So they're deeply passionate about it, and they want to make it work.
And you're in the process of creating a system to do just that, to make it simple for people to give feedback.
Yes, so part of our evaluation and monitoring of the system is that we want to know how we want to create easy ways to get feedback, right? So today we have an email address that's DBH crisis transformation at dhhsnh.gov, I believe.
Yeah.
So
Emily can put that in the chat for us.
I think Emily will put that in there for us. But the email address was just set up because we weren't sure exactly how we would continue to get feedback from folks. So that will not be the be all end all sort of long-term way to give feedback. We had also had, Beacon Health Options had created a form on their website, but it was really meant to be more internal so that the community mental health centers could give feedback directly to the access point when their connections weren't working, as well as they would like. And so we have, we've been monitoring early implementation in those two ways. The form on the Beacon website that's for the community mental health centers to easily contact the access point, and then through our email. But more importantly than either of those sort of written forms, are that we all continue to meet and talk all the time, and that I would encourage people to pick up the phone too, to tell us about their experience. And then every time that there is, that we've had a negative interaction or it just didn't go quite as well as we'd wanted, we're able to sit. Eric will listen to the phone calls himself personally and see how it went and where it went wrong. And we will circle back with everyone that was involved, and we'll try to use that as a sort of case study to get it better.
And can we circle back to Eric to talk about what the two people who've been hired at Beacon?
Yes. So I now have two team members. Carol Washam and David Hudson, both of whom are hired as behavioral health liaisons. And their job is to help me. Of course, we said earlier about how my role, my role is largely around relationships, and so is theirs. Their role is really to be additional faces of our organization, of this system in the community. They're out in the communities hosting collaborative meetings with organizations. We've got a handful on the books already, and we're working on creating even more to give folks the opportunity to join. Those will be open to the public. And so as we get them scheduled and off the ground, so to speak, in some areas, we will start making that public through NAMI and through other organizations that might be able to help us support some advertising for that. So there is also that avenue. They also support the review, like Jenny mentioned, review of calls, investigating complaints and concerns. And of course, given the fact that this is a very interconnected network of various providers, sometimes that concern is about us, sometimes that concern is about someone else, but either way, we investigate it and we try to route it to the right person to get the appropriate response.
Great, thank you, Eric. And we have just 15 minutes left here. I see that a lot of the questions got answered by you folks in the background here, but we didn't really talk about youth. So an attendee said, what happens when an underage child teenager calls 988 and has an active plan for suicide, but they refuse to go to the emergency room and or the family does not want to go to the ER?
It's tricky. I intentionally avoided answering it in the chat because I didn't feel like I could give it justice. I appreciate you
Right.
bringing it live. So I will say that we being the folks on the phone, do have to juggle certain priorities. One priority is certainly partnering with callers and their families and respecting their choice about their care. And that is a very important priority for us. But we also have a priority to protect life and protect safety. And so if we find ourselves involved in a situation where we're concerned that the life or safety of an individual might be at risk, be it a child or an adult, and we feel that we can't appropriately partner with anyone involved to create an appropriate safety plan, whatever that may look like, then we could potentially involve external agencies like 911. That would not be our choice if we had it, but at times that's when we talked about earlier, Michelle, that sometimes we're not really given much of a choice in some situations because our priority is preserving life. We will do that at times, even if that outweighs our priority to involve the consumer and let consumer choice drive.
Right. And as we've heard from Rochelle, police departments are showing up in a trained and educated way many times. So that's a safe option. I think my question is, can people under 18 call the line? What happens with that? Is it going to show up on the cell phone bill? Is my mother going to find out that I called?
So I know that there are certain agencies that have the capacity, but we unfortunately don't have the capacity to block it from showing up on a cell phone bill. It will show up. I can't make that promise. If someone is looking for the most anonymous option possible to engage with us, I would recommend going to the website and using the chat feature, because there's no record of that in a cell log, whereas you would have the phone number or text chat in your cell bill. You wouldn't have the chat information there. So that's what I would recommend. Go ahead, Jenny.
I was just going to say that crisis text line is a national resource, and the crisis text line doesn't show up on phone bills and is a very anonymous resource. So for those youth who are specifically requesting that anonymous resource, that's another place that you could point them.
Yeah.
And so will you take calls from, you can't verify age on anyone calling, right? So a person of any age can call.
If you're old enough to dial the phone, we'll talk to you.
Okay.
The only question of the consent, the implied consent of you calling is enough consent for us to chat with you. The question of consent really only arises when we start talking about engaging you in other services, because certainly if we're trying to send you for an appointment, then, are you old enough to drive yourself? Do you have the capacity to pay? Do you have the capacity to be responsible to make the choice to do that? So then we have to start having conversations about involving a responsible adult, perhaps. But there's a lot that we can do without involving an adult just to provide that immediate support via phone, text, and chat. That does not require an adult, and that does not require any kind of third-party consent to do that.
Okay, because Kelly asked, what about reporting to DCYF for use that call? That's not happening.
Only if there is a reportable concern. If we had a reportable concern, we would obviously report. But if we are just getting, we don't let DCYF know the rates of that type of call or anything. We report to DHHS certain numbers of folks that call, but we actually don't have a means of documenting, or we're not currently, I should say, reporting specifically whether that call was made with or without parental consent, because we just approach every call as a call.
Mm-hmm. Absolutely. So it's safe for youth to call. A couple more questions here. You folks took care of a lot of these. What happens when local mental health providers are too full to provide services within 24 hours?
So I think that question is related to the same day, next day appointment service. I didn't answer this one because I think, Heather may have some important information from her perspective. What I can tell you from our perspective is that our understanding is that all 10 CMHCs do have the capacity to provide same day, next day access, business day, same day, next business day access for appointments. So it's not necessarily a true 24 hours. It might be the next business day. But in some cases, that's not true. In some cases, they are doing after weekends, but I don't know that that's in every case. But every center does have the capacity to provide a level of urgent access. That is separate from kind of I recognize that there is a concern or a problem about being able to enroll in services, and this is a separate service from that. So this comes from a separate pool of resources.
I'll piggyback off of what Eric said. And yeah, so that is going to be very specific to each community mental health center. I know in our community mental health center, our team, this is what we do. We are not a treatment team. We don't carry caseloads of clients. And so we have never not been able to get somebody in within that time frame. We are seeing people on weekends if that's convenient for them. And in terms of getting enrolled into long-term services, I can't speak to that and give a definitive timeline. One of the things that we can do under the system is after this initial dispatch and after this initial rapid access appointment request, we can follow people for up to 30 days and help bridge them to these long-term services and provide additional supports in that time.
Great, thank you for that. We didn't talk about languages. What if I call and I don't speak English? What if I'm hard of hearing? Jenny or Eric?
Talking to myself now. I was just about to start typing a response. So I can tell you from Beacon's perspective. From Beacon's perspective, for phone calls, we do use the language line for people who are non-English speakers. It's not quite as good it's just not as good as speaking someone's language, but it is a good service to provide some support. The 988 network actually offers the option to connect directly to a Spanish language network. And so someone who speaks Spanish in particular might prefer to use 988 and press I think it's 2 is the option to reach the Spanish subnetwork. So that might be preferable for some people who speak Spanish. Again, that boils down to personal choice. As far as people who are deaf or hard of hearing, typically if they're going to engage with us, they might engage via text or chat. And if they do choose to engage via phone, they can use the relay services that already exist. We're able to utilize those services just like any other phone call would to be able to help communicate. And again, I don't want to speak for Mobile Crisis, but I know Mobile Crisis also has some capacity to provide support to folks who are non-English speakers. Heather, do you want to?
Yeah, absolutely. So here at Community Partners, we do have an agency that we use that has translators. And I have had, not in this role, but I have had times where I've gotten caught up just in a situation where maybe that's not available. And so I, get creative with like Google Translate or like the notepad on a phone, whatever I need to do to connect with that person, we're going to do.
Absolutely. So I just want to sort of come back around because I think I just want to be clear about the numbers, who's calling, where, when, why, what's going to happen. If I am in New Hampshire and I want somebody to respond in New Hampshire, I should call the 833 number, right?
That's one option. It really does boil down to consumer choice. I mean,
Right.
Really, I think that's important for people to understand.
Yeah.
There's not a wrong door. It's the important thing is to understand what you might get when you dial each number.
Okay.
And
So
it
can you
might
run
take-
through that quickly one more
Yep.
time?
Regardless of the phone number you're calling from, if you call 833-710-6477, you'll reach the New Hampshire Rapid Response Access Point every time. We will have the capacity to potentially link you to Mobile Crisis or urgent appointments. That is an option. If you call 988, you will always get support. I can't speak to the particulars of who might answer and what access they might have to local resources. That may vary based on your phone number. So that is a consideration. There are also some other older numbers, legacy numbers that continue to operate and feed into the system in one way or another. That's a very complicated, complex discussion. So we could talk all day about this whole question, but that's kind of the nuts and bolts of what I would say people need to think about.
Okay, and we're coming to the end of our time together. So I just want to go around and have folks quickly say what their takeaway would be in our discussion today.
And Jenny, how about we start with you?
So I think that the takeaway from my perspective is that to call early, call often, that you will get someone to talk to, no matter what number you remember in the moment of crisis. And really that we want to make sure that people are feeling like they can call whenever they need to. So I know that, like, most recently, one of the things that's really helpful about 988 being a simple number to remember is that I'm able to explain it to my 5-year-old, right? When you need police or fire or a medical emergency, you call 911. When you're feeling overwhelmed or your emotions are too much for you to handle, you call 988. That's the easiest message to remember, right? There is some nuance in this that we're
Yeah.
talking to grown-ups about, that but I think that the simplest thing to remember is when you need police, fire, or medical response, you call 911. And when you're feeling overwhelmed, you call 988.
Perfect. Thank you, Jenny. Detective Jones, Rochelle, we're going to move over to you. How about you?
I think the takeaway is, for people to just be kind to themselves, and each other, and just there's nothing to be ashamed of if you need help. It's not a weakness, and to accept it or ask for it, it's certainly a strength. And just know that we are out here, we're working together, to be better as we respond to you. So all your feedback is certainly helpful too.
Thank you. Heather, how about you?
So my key takeaway is definitely going to be, do not get hung up on the definition of the word crisis. You define what your crisis is. And so if you're feeling like you need to call. And the other thing that I would say is that this access point system is really trying to shift the attitude in terms of consumer choice, like what I was talking to earlier about working with rather than doing to. And it's really been wonderful to watch. Consent is a big part of the system. And so I just want to impart that to everybody.
Thank you, Heather. And before I get to Eric, I'm just going to remind folks that we do have an evaluation for today, and Emily will put that in the chat so folks can click on that link and fill out the evaluation. Eric?
I'm trying to think of how to boil it down. There's so much to think about, but I guess regardless of which number you call or how you do it, when in doubt, just reach out. That's what I would say, because we really will help. Whoever answers the phone or the text or the chat will do their best to help you find the resource that you need in that moment.
There is no wrong door. Just call and we'll take care of you. Great. Well, thank you all for joining us today. We do ask that you take a moment to fill out that evaluation form. You can find the link in the chat. After you fill it out, you'll automatically get a certificate of attendance if you need one of those. Just a reminder, a recording of today's discussion will be posted on the education page of onwardnh.org. You will receive an email after this presentation in the next day or so, which includes links for the survey and also a link to the recording on the website. For questions or comments, please reach out to me, mwagner@naminh.org. We thank our panel. Thank you all so very much for being with us today. This was terrific. Great information was shared. We appreciate you taking the time to be with us and sharing your personal experiences. And we look forward to seeing all folks next month when we talk about suicide prevention and high-risk groups. Until then, do take care. Goodbye, everyone.